Okay, so now we will proceed to assessing primary respiratory mechanism, and by using that we would be using something that is called listening stations. So listening stations are located on dorsum of the feet, are located on the heels, shins, thighs, ASIS, lower rib cage, shoulder, and then we will proceed to cranium to assess that. So by using listening stations, we are looking for any facial restrictions. So usually the side that is affected, or if both sides are affected, there would be facial restriction, and it will affect the mechanism, how the fluid would be transported through the body. So with those listening stations, we're looking for four qualities for symmetry, quality, amplitude, and rate, and based on those qualities we are giving the score. The score is from 1 to 3, so 1 is, or even 0. 0 there is no movement, 1 there is very little movement, 2 it's an average movement, and 3 it's a good movement. So based on that information we can see where there is facial restriction in what specific areas, and then we can proceed with the treatment. So now we will proceed with the listening stations. So the first listening station would be dorsum of the feet. Okay, so it's symmetrical, quality is good. It goes into full flexion and extension. And the rate is 10. Okay. Now we will proceed to the heels. So the rhythm is symmetrical. It's a good quality. It goes fully into flexion extension. Rate is 10. Okay. Let's proceed to the shins. Okay, the same rhythm is symmetrical. Good amplitude, good quality. It goes into full flexion, full extension. Rate is about the same. So far the score would be about 2 or 3 on all the areas. Okay, on thighs, rhythm is symmetrical, goes into full flexion extension. Rate is about 10 as well. So it's a solid 2 or 3. ASIS. good quality, it's equal on both sides, goes into full flexion and extension. Same rate. Now we proceed to the lower rib cage. Can you please hold your breath for 10 seconds? Thank you. Okay, good. Relax. Thank you. Yeah, symmetry is good, quality is good. Goes into full flexion, full extension. Now let's proceed to shoulders. It's getting weak. Symmetry is still good. It's equally weak on both sides. It goes slightly into flexion, more so into extension, but compared to other areas it's not going neither to full flexion, neither to full extension. And the rate is about 8. So based on that finding, we can make a conclusion that there is something going on with the thoracic inlet, and we would need to fix the diaphragm later. And for the vault hold 1, 2, and 3, we will readjust the camera, and we will be back here shortly. Okay, now we will proceed to the vault hold 1. So with this vault hold, we hold the head of the client in a way where we put our pinky and ring finger close to occipital bone. The ear is in between the middle and ring finger on both sides, and we are assessing the movement in this plane. Okay, so it's symmetrical, good quality. It goes into full flexion, full extension. Rate is close to lower extremities, so it's about 10. So the overall score would be in between 2 or 3. And we are assessing tentorium cerebelli. Now we will proceed with the vault hold 2. So we will hold the client's head, the occipital bone, in our one hand. The second hand would go on the frontal bone, and we would assess the movement in this plane. So we would assess falx cerebellum. Okay, so the movement of frontal bone is restricted. So it goes slightly into flexion, slightly into extension. So the score would be 1. Okay. Good. Okay, now we will proceed to the vault holds 3. So we would palpate for a greater wings of sphenoid bone. We would be assessing sphenobasilar synchondrosis. Okay, so it's symmetrical, good quality. It goes into full flexion extension equal on both sides. So the score would be in between 2 to 3. Okay, so based on our findings, we can conclude that there is a restriction around the thoracic inlet diaphragm that aligns with the restriction when we were assessing for PRM. Also, there was the reduced movement of the frontal bone, and it aligns with the client's main concern, which was his neck pain. So for this case, on this client, we would use 3 techniques. We would use a thoracic inlet release, which would be local technique. We would use occipital cranial base release, which would be global technique. And we would use a frontal lift, which would be a focal technique. So we will start with a thoracic inlet release. So with our caudal hand, we would find the C71. With our cephalic hand, with our caudal hand, we would find the clavicles and the manubrium. We will then look for the direction of ease. We engage the tissue and we hold. And under our caudal hand, we can feel that there is some tissue remodeling happening. And when the body is done remodeling the tissue, it will sort of push the hand out of the fascia, which is about now. So we disengage. Now we will proceed to the occipital cranial base release. Okay, now we will proceed to the occipital cranial base release, which would be our global technique. So we would place our fingers into the occipit. We would find the transverse process of C1, and we would spread C1 from the occipit bone, waiting for the tissue compliance. platform with our fingers. We find the space in between occiput and C1. Fingers goes straight into the orbit facing the ceiling. We wait for when the head is dropped into the palms of our hands. Good. Now we hold the transverse processes of C1 and with our fingers 3, 4, 5 we slowly disengage occiput from C1. Okay. Good. And then we are resetting condyles laterally from the foramen magnum.